The most common cause of our VQ on the Q side, perfusion side issues, let's talk about pulmonary embolisms. Now, our lungs are ventilated, but they're not perfused. We have a pulmonary embolism. We've got a block in the pulmonary system. So our lungs are ventilated, but our lungs are not perfused. So our VQ ratio is greater than 1. So our Q is our perfusion, very obviously, right? Q stands for perfusion. So our perfusion has gone down. Our numerator has gone, it's static. So our VQ ratio is greater than 1. And here we've got an obstruction of one of our pulmonary arteries. So we've got a clot here in our pulmonary system. And, a clot forming here is reducing circulation to our alveoli. So we've got air coming in and out to our alveoli unobstructed. We've got air coming in and out just fine, but I don't have circulation going through our alveoli. So even though I've got air coming in and out, I've got nothing to swap our gases with. And you might think, well, a little clot in the pulmonary system, that's not too bad, but these bad boys can get pretty bad, right? So here's a nasty, gnarly pulmonary embolism. That ruler down there, left to right, is 6 inches long, and you know what? This guy didn't do so well, right? So these embolisms start in one area and they just extend as long as they can. A good friend of mine who is, I will say, she is still alive and living quite happily, had a pulmonary embolism that reached from her lungs down to her calf. So these embolisms do go a long way. They do. It's not a little heart attack. It's not a little stroke. Where just one little clot, one little obstruction causes symptoms. We're dealing with kind of a major issue here when we're talking about pulmonary emboli. Signs and symptoms wise for your pulmonary embolism patient, definitely dyspnea, right? So we're talking about respiratory distress patients, so they're going to have respiratory distress. Going to be a little tachypnic, right? They can't take a full breath, and they're going to have chest pain. But this chest pain is going to differ from cardiac chest pain because it's very pinpoint. So I have a very sharp pain, and it's pinpoint in my chest. I can point to it. It's not diffuse. So your cardiac patients, cardiac chest pain patients are going to have diffuse chest pain most of the time. Your pulmonary embolism patients are going to have chest pain that's very pinpoint, and I can point to it. Right, I can point to a point, the point on my rib cage, and right here. Right here is my pain, and it's very sharp, and it's right here, and I can point to it. That tells us almost immediately that it might be a pulmonary embolism. We can think of this as a pulmonary infarction. So we've got myocardial infarctions, or MIs, or heart attacks. We've got cerebral infarctions. We've got our cerebral attacks. We've got our strokes. Well, this pulmonary embolism, this is a pulmonary infarction. I've got pain right here, and I can point to it, and it's very pinpoint, and it's sharp. And this is going to increase my pulmonary vascular resistance, which will in turn increase right ventricular afterload. It's going to put a stress on the right side of my heart, the right atrium, and the right ventricle. If we were to take some labs for this patient, so this pulmonary embolism patient, we would see a low PaO2, because I've got this interruption in circulation. So I've got oxygen coming in. I've got no issue with ventilation. Air is coming in and out. I've got an issue with circulation. So air is coming in and out, but I'm not unloading oxygen onto my hemoglobin. So if I were to take labs, I would see a very low PO2. I would see a very low PCO2. So our CO2 would be low as well because I would be in a respiratory alkalosis. With this patient, got a pulmonary embolism, got a VQ ratio issue, and it's on the perfusion side. So I've got good ventilation, I've got air coming in and out, but I don't have any circulation. With that O2, so I don't have exchange because I don't have any circulation. So I don't have exchange of oxygen onto my hemoglobins. With my CO2, I've got pain, I've got chest pain. I'm going to be a little tachypnic, so I'm going to be offloading. I'm going to be breathing off a lot more CO2. So I've got oxygen coming in, but I can't unload it to anything because I don't have the circulation there. I'm going to have a respiratory alkalosis, so a high pH, because my CO2 is low, because I'm breathing a little bit more fast than I should, a little bit more quickly than I should, because I'm in pain. I've got a lot of chest wall pain, a little bit tachypnic, so I'm breathing off a lot of CO2. So I've got a low O2 and I've got a low CO2 with our pulmonary embolism patients. And then at the hospital, they're going to draw what's called a D-dimer. And that D-dimer really tests and kind of zeroes in on whether or not you're clotting within your pulmonary system. So we're pulling in all of this patient assessment information and then drawing a D-dimer and saying, is my D-dimer elevated? And if so, we might be thinking PE. We can even look for pulmonary embolism on our EKG, even on our 3-lead EKG. I know you guys haven't gone through the 12-lead course yet. We'll do that in the fall. But even on the 3-lead, we can look for a PE. This is a rule in. This is not a rule out. So about 20% of our pulmonary embolism patients show this on the EKG. So again, this is, if you see this, this is a rule in. But if you don't see this, this is not a rule out. So about 80% of our patients with PE do not show these signs. So this is not a rule out. But if you see this, it's an S1 Q3 T3 pattern. And what that means is there's an S wave in lead 1, there's a Q wave in lead 3, and there's an inverted T wave in lead 3. So S1 Q3 T3, S wave in lead 1, Q wave lead 3, inverted T wave in lead 3. So in here, we see lead 1 here, there's an S wave, there's a negatively deflected S wave right here. There is we look in lead 3, there's a Q wave right there. That first negatively deflected wave is a Q wave. And there's an inverted T wave. We can see that inverted T wave right here. So if you see that S1 Q3 T3 pattern, that is a rule in, not a rule out, but a rule in for PE. If you don't see it, but you see other signs of PE, that is not a rule out. But if you see this S1 Q3 T3 pattern, that is a rule in for pulmonary embolism. Some risk factors for pulmonary embolism: anything that could cause a clot, really anywhere. So recent surgery, your body's going to clot, produce clots, send them anywhere. Long bone fractures, again the same thing. Your body's trying to heal, send clots anywhere. Pregnancies and oral contraceptives, you're at greater risk of clotting internally and just kind of throwing some clots. And if you are a smoker, you are at greater risk for producing clots and producing a pulmonary embolism. So what in the world are we gonna do for pulmonary embolisms? Well, we can't really fix that, right? They need surgery. This patient needs surgery. This patient needs heparin, needs an anticoagulant. So what we are going to do in the short term, we're going to support their ventilation. We're going to treat any hypoxia that they may be experiencing. We're going to get them to the hospital. If we can start heparin out in the field, we're going to do so. And we just need to get them to surgery as quickly as possible because that is going to be definitive treatment. If you have any questions, comments, concerns, or cuss words, please let me know.